Hi everyone, this is a video on family medicine traps. These are concepts that I found really tricky on the CMS forums, and I thought I would just make a video about them just so I can learn, and hopefully these concepts help you guys learn and prepare for step two and your shelves. Question number one, which therapy is most likely to improve survival? 62-year-old man with prior MI and type 2 diabetes presents with dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, crackles, and an S3 gallop. Chest X-ray shows cardiomegaly, cephalization, and curly B lines. So, what therapy is going to help improve survival for this individual? So it looks like he's having some kind of heart failure symptoms, especially with the orthopnea and the dyspnea. It sounds like a left heart failure. So remember that the therapy that's going to improve survival for heart failure is ACE inhibitors. Remember, they reduce mortality and they're also part of like the GDMT. So we know that these improve symptoms and improve mortality, so we want to choose this one. Question number two. So this is a 66-year-old woman who presents for routine health maintenance. She had a normal PAP and HPV screen 5 years ago, a normal mammogram 1 year ago, and a normal colonoscopy 8 years ago. Which screening test is most appropriate at this time? So for this individual, we would want to do a DEXA scan. So the reason why I found this really tricky is because I thought that she would also be due for the HPV and Pap smear again because it's already been 5 years. But the key thing here is you can stop doing Pap smears after age 65 if they have prior normal screenings. So that's why we're choosing DEXA scan instead of the Pap smear. The other options were FOBT. That's not needed if the colonoscopy was normal and with an interval. So her colonoscopy was only 8 years ago, and it was normal. So her next one would be in 2 years. So she's not due for it, so she doesn't need the FOBT. CA 125 is not a regular screening tool, so we don't really want to select that one. And then AAA ultrasound, that's more for people who have history of smoking. So you don't choose that one either. All right, next question. Question number three. A 65-year-old woman has a DEXA scan showing a T-score of minus 2.8. She's already taking calcium and vitamin D. Her 10-year ASCVD risk is 5.7%. Alright, so everything looks okay except her T-score it's below, or it meets the criteria for osteoporosis, because remember osteoporosis you need minus 2.5. So what's the most appropriate treatment here? The answer is alendronate therapy. Alendronate is a bisphosphonate, and that's the first line for osteoporosis. And again, remember that a T-score of less than or equal to minus 2.5 is osteoporosis. And there's, I think, between 2 and 2.5 is osteopenia. So for osteoporosis, you would start a bisphosphonate. The trap here was she had like I guess it's not relevant because I didn't add that into the question stem. But other thing was that she had high cholesterol, but her ASCVD score, as we saw in the question stem, is within normal limits, so we don't really need to start a statin. Again, calcitonin, that's a second line agent, so we want to choose the first line first. Raloxifene is an alternative, but it's not the preferred first line again, and no further treatment. That's not the answer because osteoporosis requires pharmacotherapy. Question number four, what is the most appropriate initial therapy for a 65-year-old man who has 5 years of gradually worsening constipation? He has hard stools, straining, normal labs, normal colonoscopy, and no red flag symptoms. So everything looks good except for his constipation. This is his first time seeking treatment, and he's also increasing water intake. So what can we add for him? And since it's his first time, I think they would want us to choose something that's more of a lifestyle change. And the most closest answer choice I could see to that is psyllium husk. So psyllium husk is something, it's like a fiber supplement that helps firm up the stool, or not firm up the stool, but give it I don't know exactly. I thought it was firming up the stool, but I guess you don't want to firm it up more because it's already pretty firm. Um, but I guess the fiber helps in unclogging the colon and helping the individual poop. So again, if constipation is uncomplicated and untreated, we want to start with lifestyle modification. So he's already drinking water, so then we can add fiber to his diet. And then after that, we can add all the other medications that we can add. One thing I found out when I was like looking the stuff up is that magnesium citrate, we wouldn't choose that one because that one's more of like a one-time thing, like you don't want to take it daily. So that's the reason we don't choose that one. Question number 5. A 55-year-old man has 18 months of progressively worsening difficulty reading and seeing small objects. His symptoms improve with stronger reading glasses. He's otherwise asymptomatic. His visual acuity is 20 out of 30 in one eye and 20 out of 20 in, sorry, I don't even know how to read this. So visual acuity is 20/30 in one eye and 20/20 in the other. So I think that's how you read. Haven't done my ophthalmology rotation. Okay, so what is the most appropriate next step for this person? The answer is no further management is indicated. So here it looks like his vision is improving with stronger reading glasses. And basically his vision is back to normal, so we don't really need to do much, and it looks like he has no red flag symptoms, he has no pain, he has no like blurry vision, so we don't really need to work him up and do unnecessary testing. Question number 6 is 76-year-old man with a history of chronic sun exposure presents with 5 years of progressive redness and scaling over bald areas of his scalp. He is a retired sports coach. The scalp shows rough, scaly papules on sun-exposed skin. And what is the most likely diagnosis? So I don't know why I got this question wrong, but I did, and the answer is actinic keratosis. So I think I chose like seborrheic dermatitis just because what the image looked like. Um, but like just I guess like the image had like more of a yellow colors and it was like near the hairline, so that's why I chose seborrheic dermatitis. And yeah, I shouldn't have done that. Like the history and like the history of the sun damaged skin like clearly points to actinic keratosis. So hopefully this reminds me of not choosing that in the future. The NBME trap was psoriasis. So the image like showed like kind of a scaly plaque, but the location wasn't really correct for psoriasis. So that's why that's not the answer. But the rule or like the key thing we should take away from this question is that if you have sun exposed skin and it's a rough like sandpaper like papule, then you want to think actinic keratosis. If you want to choose seborrheic dermatitis like I did, there they would describe the patches to be more greasy and not rough. Um, all right, question number 7. A 52-year-old woman was visiting from Egypt, has hypertension, and speaks very little English. Her daughter offers to translate. The patient ran out of her medication 2 weeks ago. Blood pressure is 175 over 105. She has a headache, but otherwise normal exam and vital signs. So, what is the most appropriate next step? And the answer is arrange for telephone interpreter services. So here I got really tripped up because I chose to like send her to the ED immediately just because of the headache and the high blood pressure. But it makes sense to get more history first. Like, you obviously wouldn't want to send a person without getting any history or any background, and send them straight to the ED. So, yeah. Remember to always get a full history before you go on and move on to other steps. And that's the last slide. So hopefully these concepts help you out in the future. And good luck on your step and shelf exams. Bye.